Welcome to ECHOMAP, the practical, easy, and above all useful ultrasound tool for general practitioners. So today we're going to look at a musculoskeletal clinical case. Really not obvious. And you'll see, it's not for the reason we think. And I'll show you that in musculoskeletal, you also need to know how to think a little outside the box. So, as usual, if you like this channel, if you find that it brings you something, subscribe to the channel, put me a like. It really encourages me to keep making these videos for you. At the end of my consultation, real and authentic clinical cases, or when I'm faced with a particular difficulty, as was the case today with this patient I just saw in consultation, well, I think of you. I think it's going to make a nice clinical case and I have to tell them about it because it can help other people. Same on Facebook, put me a like, subscribe to Facebook to be kept informed when new videos are released. Plus, your ultrasound training is free. The link is in the description, so I really invite you to join me in this training too, and learn how to use your ultrasound machine correctly, progress at your own pace, and really be of service to your patients. And most importantly, to have a lot of fun on your machine, because I find that ultrasound is really something that can take us out of the complexity of a GP's job. So the clinical case is a 73-year-old patient, dynamic, active, in good shape, and who comes to see me because for a month, in fact, things haven't been going well. She's limping, her right buttock hurts, and she thinks she's got sciatica. So I make him clarify a little bit, obviously why. And in fact, she slipped coming out of her bathroom, quite simply. The floor was a bit wet, the tiles. Her leg went a little bit forward, it did like a little bit with, say, a kind of mini split, and since then, she's had pain in her buttock, and for her, she's moved the vertebra, and she's got pain in her buttock because she's got sciatica. So we're going to do, of course, the clinical examination. The clinical examination is surprising. He finds pain in the lower part of his right buttock. So the patient is lying on her stomach, and here I am, with my knowledge of anatomy, thinking I'm going to have to take a look at the proximal insertion of the hamstrings, since we know that the hamstrings insert at the level of the ischium. So the ultrasound machine is always ready next to the patient. So I pull out the ultrasound probe, and this is the image I get. I'm sure you'll agree that this is catastrophic. I tried to adjust the image, I tried to improve, but very clearly, the image depth and echogenicity of this 73-year-old patient make that, overall, you don't get much out of this ultrasound, so musculoskeletal equals high frequency. Because obviously, you need the right resolution to be able to explore tendons, and here, we're looking for a rupture, necessarily, of our joint hamstring tendon, and honestly, that's not going to be possible with this probe. What do we tell the patient? Do we tell him, that's it, we can't see anything, let's move on, it looks like it's there anyway? Pain really did stick always, I remind you of that echo palpation story. As soon as I pressed on the probe, it really hurt there. So it was a good fit here with what we're guessing is the ischium, which is really the bony area of the pelvis on which this tendon is going to insert. But even so, the image is largely insufficient to say anything about it. Well, this is where you have to think outside the box. In everything that's going to be exploration, especially of the hip, the use of the abdominal probe can really help you. I'm convinced that a well-tuned low-frequency probe sometimes does better than a high-frequency probe that's going to be completely saturated in terms of its settings. You can see that by switching to the abdo probe, then obviously you increase the frequency of your abdo probe, improve contrast, manage its depth, and so on. We do a lot of things. Well, here we're able to visualize the ischium and tendon insertion much better here. Conjunctively proximal with already a hypoechogenous image, not very fibrillary, a little heterogeneous here with small hyperechogenous stakes. And I think you'll agree that we see much better in low frequency here than we did earlier in high frequency. So, to keep progressing, there are some musculoskeletal ground rules that will get you out of a tight spot, because I think we're on the wrong track here. We've got a diagnostic hypothesis. The ultrasound machine is saturated to the max. We're going to have a hard time. Well, bilateral is comparative. Always examine the contralateral side first to better deduce pathology on the pathological side. Here we see that we have our ischium, we're on a transverse section, and here we have the really terminal part of our conjoined tendon, which is well-rounded, which is hypoechoic because there's anisotropy in this tendon, which has a slightly unusual shape. And let's compare with the other side. There's no thickening of the subcutaneous tissue here. We've got a broadly similar look. Our ischium is a little bit different. We've got some hyperechogenic little stakes, as we'll see in a moment. Most importantly, the appearance of this conjoined tendon is extremely different. A tendon that appears enlarged, hypoechogenous irregular, with here a large hypoechogenous patch that appears to be protruding from the tendon. We have a small image of an echogen here in depth as well, which could very well be a deep hematoma located beneath the tendon. So you see, the comparative bilateral will open our eyes and enable us to see much better the things that need to wake us up. The double grid, then the double grid, of course, always performed at least one sagittal section and one transverse section. Here we are on the cross section from earlier. It hasn't changed with this heterogeneous aspect. And in sagittal, here we see our tendon very clearly, greatly increased in volume, very hypoechogenous, with a total loss of the fibrillar aspect, a heterogeneous aspect here, once again, of the ischium. So we start to think strongly about a rupture, a disinsertion of the proximal part of our hamstrings. So you need to know your camera settings to get out of a tight spot, because let's face it, when a patient is not very echogenic, when an image is too deep, when you can't get out of it, your machine always has a solution for you as long as you know the settings. Sometimes it's going to be playing on frequency. Sometimes it's going to be playing with the power of ultrasound emission. Sometimes it's going to be playing with contrast. There are lots of settings, and that's what makes the ultrasound machine so rich, but also so complex. And there's bound to be a setting or set of settings, like here, for example, the focus, that will make you improve your image quality even further. As you can see, we're starting to see much better. Here, our conjoined tendon, we can clearly see here the loss at about this level of the fibrillar aspect, with which it will be replaced by an anechogenous zone. We're getting a better look at the irregularity here of our ischium, with here again a small hyperechogenous image. So you can see that by improving image quality, you gain additional information. Very important point, because here I'm showing you still images. We always get an idea of the problem in dynamics. Ultrasound is a dynamic field. Next, we take photos to print our reports. But for us practitioners, it's really in the dynamic that we're going to come out on top. Send us a sneak preview of what it's like. In dynamics, I find that we see much more of the irregularity of the cortex of our ischium, especially if you've done a bilateral comparison before. So we've got a reference image in our heads. Here you can see the highly irregular cortex. The fibrillar part of our tendon is also clearly visible. By the way, I find that you can see tendon fibers much better dynamically than statically. And here we can clearly see the interruption of the fibrillar part, which is going to be replaced by this wide anechogenic patch. We can direct our probe, as I'm doing here, to see a little more of the tendon. This allows us to estimate anisotropy. See that when I changed the position of the probe, my image remained anechogenic, which leads me to believe that there is no tendon fiber in this image, since it actually remains anechogenous despite the change in probe position, so probably effectively a rupture of the insertions. Proximal tendon. I was able to go a little further to see the rest of my tendon by aligning the fibers a little more. Here we can see very clearly our conjoined tendon with its fibrillar aspect, and here we can see the interruption of this aspect. Yet fibers don't change direction. So you see the dynamic, the probe play with the hand, is going to be essential if we're going to be able to pull our weight in difficult diagnoses, difficult patients, or structures like here, complex, deep, because I systematically find hamstrings, their proximal insertion, extremely difficult to study. Of course, knowing your anatomy will help. If you know what you're looking for, if you know what the basic structure looks like, because you've studied anatomy, but you've also looked at lateral control, you're going to be much better at studying musculoskeletal. Here, in this patient, we had the most lateral part of our tendon that appeared overall fibrillar all the way to the ischium, while the most medial part of our tendon was totally anechogenous with an impression of fibrillar rupture. Well, that explains it, since here it's actually the coming together of our biceps femoris and semitendinosus that will create a joint tendon. So we probably have here, I say probably in this patient, a rupture of the semitendinosus with probably a persistence of the tendon of our biceps femoris at the level of its insertion on the ischium. You need to integrate the clinic into your reasoning, of course, and in particular echopalpation. Here the patient tells us about a slip with a stretch. We're not going to start with sciatica. We're going to start with something about a rupture, a disinsertion, given that it's a brutal trauma. The lesion was a month ago. If we just finally had a little stretch, it would be a long time since the patient walked normally again. So let's think about something more severe. Here, The ultrasound shows us an anechogenic image with loss of fibrillar appearance, which would be consistent with a rupture of the tendon insertions. And ultrasound isn't all powerful. Now that's something to keep in mind. You'll have moments when, no matter what you do, you come up short. I'm not saying you won't get out of it at all, but you will have a tough time. And there's no need to get frustrated about it. Ultrasound is something that has its limits. Because of its physical mechanism, sometimes ultrasound penetrates poorly, returning with difficulty to the probe, and you'll have difficulty obtaining an image. But I really think that on obese patients, you should always keep in mind that the low-frequency abdo probe, and they've come a long way in recent years, can help you make diagnoses. I can't count the number of times I've managed to diagnose proximal phlebitis of a lower limb in a very obese patient with very large legs, thanks finally to the abdominal probe, while the linear probe, which is normally the probe used, had absolutely no use. The image was absolutely catastrophic. So remember, when you're in trouble, to use the low-frequency probe, even if you would naturally have used a high-frequency probe. Another example here that I didn't use, but I did there in practice, I didn't keep the images because it didn't help me. But sometimes the low-frequency probe will help you spot the structure you're interested in. And then you change, rest your low frequency, and switch back to high frequency, positioning the probe in exactly the same place. And sometimes that can help you go straight to the right structure. Because sometimes you need to have a wider field, a bigger view to be able to find your way around. So if you like this video, put me a like, subscribe to the channel, same on Facebook. And don't hesitate to take this introductory ultrasound course. I'm always trying to bring you more. I'm adding new clinical cases regularly, so now's the time to do it. See you soon on ECHOMAP. Bye bye.